Okay, I know that our journey in Grand Cycle 8 is going to be far more successful than the way we open these webinars. So thanks for bearing with us. I think it's a lesson too in terms of how we just need to adapt to some of the new realities that we're facing. It's fantastic to have such a very large audience for us today to talk through the guidance for our country applicants for the Global Fund's Grand Cycle 8. Today we'll talk through the investment materials for health and community systems known as RSSH, HIV, TB, and malaria, and some of the key messages that we have. But first, I think stepping back, we saw in 2025 a very turbulent year for global health and for international financing for health. And these effects will continue into Grand Cycle 8. The Global Fund had a successful replenishment at the end of 2025 within that difficult context. But the reality is that allocations to countries for Grand Cycle 8 will be predominantly lower. And looking ahead, the financial prospects for the next Grand Cycle 9, will be even harder. So the Global Fund is adapting to these new realities, and Grand Cycle 8 must and will be different. This has already been discussion by our board and by our strategy committee, which in December agreed some significant strategic shifts and adaptations for Grand Cycle 8. And these materials are reflected and emphasized in the Grand Cycle 8 materials that are now on the website. And I think an important and first message for all our country audiences today, and our partners as well as the Global Fund country teams, is that we will need to tailor and adapt these changes to each unique country context. We're going to need to work much smarter and better together. The changes that we'll walk through will not be easy and demand some hard but necessary choices. And so today's session aims to help you in your critical roles on what we'll do differently in Grand Cycle 8 to deliver and sustain national strategies and the Global Fund's mission. As you saw from the agenda, we'll walk through the materials and have some time for Q&As. And as Marcella's asked, if you could put your questions in the chat, that'll allow us a little bit more time to have a structured approach to answering your important questions. So deliver results for health in the new context, we'll make 6 important shifts through Grand Cycle 8 to keep the Global Fund's investments catalytic. And these are reflected in the introduction sections that you'll see in RSSH, HIV, TB, and malaria information notes. The first message is adapting to new realities. Countries need to use Global Fund investments together with partner and domestic investments differently and more holistically to achieve and sustain public health goals. So Grand Cycle 8 is certainly not business as usual. A key theme for Grand Cycle 8 is integration. And while this is not a new theme, it's a theme that we want to give more energy to as a means to drive sustainability, effectiveness, and equitable access. And critical here will be how we support each country to accelerate progress on integration, reflecting each country's unique progress to date and the unique context that you have in your primary healthcare settings. We need to push value for money far more. We saw already many countries successfully do this as part of the Grand Cycle 7 reprioritization and revisions, and every public health dollar must be used effectively. So value for money must be top of our thinking. In terms of the use of the Global Fund investments and delivering results, prioritizing and targeting populations most at risk remains very key to reducing mortality and incidence and driving results. And we're also going to see in Grand Cycle 8 continuing push to increase self-reliance in public health, increase domestic financing for health, preparing for transition from Global Fund support, and more specific financial commitments from ministries of health and governments for HIV, TB, and malaria. And this will be in line with the Global Fund's updated sustainability transition and co-commitments policy, and there'll be a session on January 24th on that. And so, for example, under this, we're looking in terms of how we can work with countries, for example, to cover higher amounts of first-line treatments, or covering community health workers as a key part of the responses to the 3 diseases and primary healthcare. And a 6th key message for us is about innovations, continuing to support countries to access and scale up innovations for HIV, TB, and malaria in terms of products and in terms of services. Also leveraging some of the catalytic funds that will be approved by our board for that. So these are the top line messages, and they will be reflected in the information notes and in the discussions and presentations that you will now hear. You go to the next slide. I also want to highlight that some of those changes is already reflected in the improved investment guidance for Grant Cycle 8. We've taken some important lessons from the Grant Cycle 7 reprioritization. We're far more robust on prioritization and more attention to how we optimize investments, including through integration, mainstreaming community rights and gender, and not looking at community rights and gender as something separate, but really part of our core responses for HIV, TB, and malaria. And also you'll see, again, on that theme of integration, a greater coherence and cross-referencing across all the information notes that we have published. You go to the next slide. Here's the timeline. I think points to notice here that because of, I think, the difficult environment that we were in, the replenishment finishing later in 2025, that we are on a compressed timeline to have grants signed by the end of this year for those countries, and that's the majority of countries, where the current grant cycle, 7 grants, are ending at the end of this year. So we're going to be doing a lot in more compressed timelines. And part of this session is really working with our country stakeholders to make the preparation so that we go through this process and deliver quality funding requests to the Global Fund starting right now. The allocation letters will be sent out to the countries in March. That will be after the February board meeting, and then countries will have time in terms of developing and submitting the funding requests. But let's now turn and talk through in terms of what's in each of the information notes that we have published. So let me turn over to Shun on RSSH.
Thank you, Michael. Good morning, good afternoon, and good evening. My name is Shun Mabuchi. I am the head of RSSH and panel preparedness and response. Next slide, please. So this is a table of contents of the RSSH PPR information note. And there are 10 areas in RSSH and panel preparedness and response investments: health sector governance and integrated people-centered services, community systems strengthening, health financing systems, health product management systems, human resources for health, including community health workers, integrated laboratory systems, medical oxygen and respiratory care, and M&D systems that include data and digital systems and holistic early warning surveillance systems. And 2 new areas of reducing human rights barriers and reducing gender-related vulnerabilities and barriers. Next slide, please. What's new about the GC8 in RSSH and PPR? I will say 4 main things. 1, we are suggesting what to prioritize and what we discourage across 10 thematic areas, all of them. In prioritizing investments, we encourage the use of maturity models to understand key gaps in your system's functions. And partners and the Global Fund work together to make the maturity model assessment tools available for community health workers, laboratory systems, supply chain systems, early warning surveillance and response, community responses and system strengthening, and digital health and DHIS2. Second, as Michael said, integration of HIV, TB, and malaria services into primary healthcare and health systems based on country context is imperative now, as siloed vertical programs are no longer sustainable in the current financing situation. So in our guidance, integration is encouraged across all thematic areas, as well as is in HIV, TB, and malaria information notes. And in general, we discourage disease-specific workforce and other systems investment unless strongly justified. And Australia will later briefly share key messages on integration. And I highly encourage you to read our technical brief on integration that provides details of how you can use the Global Fund mechanism to accelerate integration in your country. Third, our information note reflects the overall transition approach. And it suggests transition away from health worker remuneration, program management, and operation costs for equipment and infrastructure, particularly in upper middle income countries, and ask remuneration in lower middle income countries to have a co-financing or sustainability plan with clear timelines. Four, other emphasis, optimizing health systems funds across Gavi, World Bank, and US and other bilateral funding, community engagement strategy to address access barriers and enhance integration, and health security and climate activities are all integrated in all of the RSSH thematic areas so that you can address them through RSSH investment. Next slide, please. I talked about the three thematic areas on the right, on the left, and overarching direction across these areas is to prioritize integrated approaches, systems maturity building, and sustainability measures, and discourage disease-specific interventions and short-term one-off capacity building activities. Next slide, please. And this slide shows some examples of high priority activities versus lower priorities. And I already talked about human resources for health example, but just to reiterate the points, as this is a good example, we are aiming to support integration and sustainability through RSSH investment. So if you can see the third row on HRH, the priorities in HRH investments are on investment in integrated primary healthcare workforce based on national human resources for health and community health strategic plans. And we support what you would need to build more domestically funded sustainable HRH systems, such as HRH analytics, policy and planning, harmonization of pay scales, task sharing reforms, and pre-service training. And we discourage recruitment, remuneration, and deployment for new single disease, HRH, and CHW investments. And also remuneration, as I said, in upper middle income countries and remuneration in lower middle income countries without a co-financing or sustainability plan with clear timelines. And we have much more details for each of the thematic area in the information note. Next slide, please. On the collaboration with Gavi and the World Bank and GFF, Global Financing Facility, our intention is to optimize external funding, including ours, for your priorities. So this is a non-exhaustive list of collaboration opportunities identified based on our multiple conversations with them. But of course, the real opportunities are country-specific. So we want to ensure coordinated investment planning across the Global Fund, Gavi, the World Bank, Global Financing Facility, the US government, and other bilateral investments throughout our funding request and grant-making process. And we will support you doing that as much as we can. Again, I couldn't go into each thematic area, but I believe that InfoNote for this cycle is the clearest in what we encourage you to consider in the current context. So please take a look as you work on the funding request. And I'll stop here and hand over to Beatrice for HIV information note. Thank you very much.
Hi, everyone. My name is Beatrice Tomé. I'm an HIV advisor with the team. I'll be happy to walk you through some of the highlights of the info note for HIV. So next slide, please. We have the table of contents of the GC8 info note. You see that we'll have a common messaging on bold prioritization for GC8. And these are aligned across the info notes and aligned with what Michael just presented to us. Then we have a session on key messages for HIV funding requests. We have a section on program essentials that we're keeping for GC8, and we'll get to those in a second. A section on health product considerations and how to unlock efficiencies through a health product optimization, etc. Then we have the list that you're more familiar with of HIV investment going by module, aligned with the modular framework. just highlighting that we've integrated modules on reducing human rights and gender-related barriers, as well as community systems and responses, even though those are sort of hosted in the RSSH modular framework. We have specific sessions in the HIV info notes for what's specific to HIV programming. And similarly, we have a section on strategic for HIV. On next slide, please. Some of the updates, you see that we've incorporated the technical updates of the past few years. So this will include updates from WHO guidance that you've seen come out last year. We've updated some of the program essentials according to the latest guidelines, and we've introduced a few new ones, and we'll look at it in a second in a separate slide. We made an effort on cross-referencing other information notes, namely RSSH info note, TB info notes, really to streamline and to avoid duplication of messaging. We also have a lot of reference to other external partner guidance as well. So you see as an annex a list of key references for HIV programming as well. You also recognize that the info note is really built upon the Global Fund reprioritization approach that was published last year, so which a much stronger emphasis on the key investment decisions given the challenging financial context. So you see this over and over again. Something that we've introduced, and you see similarly in other info notes, is to list some of the priority activities versus some activities that are lower priority that will require some sort of justification for funding this coming cycle. We're also introducing sections on optimization and efficiency considerations to support prioritization. So for the first time, you see that we're introducing, for example, incidence and prevalence-based thresholds for some of the prevention interventions, as an example. And you see that the value for money decision-making process is again much more reinforced in the info note as well. As Michael already mentioned, there's a big push for integration. So in the HIV info note, you see some of the opportunities for better integration across sectors and within the health sector itself. So you see some suggestions for that. The next slide, please. So some of the key messages that are specific for HIV, you see that there's a lot of content in terms of how to best invest for impact. So again, trying to help applicants determine the optimal mix and scale of interventions. So more than ever, really use data to drive decision making. And we're also suggesting the use of analytical tools for cost effectiveness as well. And WHO itself has published guidance on HIV prioritization a lot based on the use of those tools. So we're really encouraging the use of such tools. We're also suggesting to scale back or just not fund less effective interventions as well. So it's not only about investing on what's more cost effective, but it's really moving away from what is not. There's a lot of message on focusing on high impact interventions. So as examples, and this is not exhaustive, in terms of HIV prevention, we're really trying to reach the people and the locations where there's the greatest needs for HIV prevention. Similarly for HIV testing, so how can we refocus testing programs to really reach and offer testing for those most in need at greatest risk. ART scale up as well as sustained viral load suppression continues to be a big priority, also in terms of its role in terms of containing the epidemic. And all of this with all the supportive interventions that will address barriers such as the gender-related, human rights-related, and all the RSSH investments that will support all of these interventions. We're suggesting to enhance collaboration between government and community organizations, also with an eye on sustainability, and continue to invest in community systems, peer-based approaches, and linkages. Just trying to look at what are the more cost-effective ways to do that. Again, so we're continuing to support improving access through reducing human rights and gender-related barriers to care, strengthening community systems, so prioritizing rights-based, gender-responsive programs and services that are designed with and for key and vulnerable populations, and we'll speak more to that in a second. And continue to invest on protecting safety and security of data, staff, and clients. This remains to be a priority. Again, there's a big message on demonstrating value for money. So it's not only going to be about what we fund, what we invest on, but also how we do it. So how do we provide service delivery? There's a lot of opportunity to look into cost effectiveness of service delivery itself. And again, leveraging integration opportunities. So as examples, integrating HIV services with other relevant services, including sexual reproductive health, maternal child health, etc. Looking to community-based services, pharmacy-based services, etc. All of this while still providing people with choice. We know that for HIV, obviously, this continues to be very important in terms of the options and services they receive, and differentiate, tailor how they receive them. Also looking not only at access, but also looking into cost effectiveness. So we know that there's several examples of decentralized community services, task shifting, multi-month dispensing, etc., that we know also support cost effectiveness. And again, optimized system support, mentioned task shifting already, couldn't highlight this enough, and structured quality improvement approaches. Next slide, please. So I won't get into the detail of the program essentials. So if you remember, the program essentials were introduced in GC7, and we felt it was a good set of essentials that countries should try to incorporate in their HIV programming. So we're keeping them for GC8. They have been, again, pretty much maintained. There are a few new ones. So there's a new one on STI screening and treatment for people at increased risk of HIV. There's a new one on looking into triple elimination as well. A new one on TB HIV services, looking into how to more efficiently diagnose TB among people living with HIV. And there's a new one looking into gender-based violence. Next slide, please. So these are just a few examples of prioritization that we've included in the info note, and you recognize it from the prioritization approach that was published. So just a few examples. So in terms of prevention, for example, some of the top priority interventions remain to expand availability of condoms and lubricants at informal sites managed by local actors wherever possible. So we know that this is also a very cost-effective approach, and potentially deprioritizing, depending on the context, female condoms, procurement, for example. We know it's a higher cost, more limited use, again, with decisions being made in terms of where the demand is high, continue to keep the availability. But just to give examples of specific suggestions that we're making in terms of the HIV investments. Again, for PrEP introduction or expansion, we're also suggesting a few thresholds in terms of prevalence and incidence to guide introduction and expansion. And again, this is the first time that we're trying out this approach for prioritization. And for example, deprioritizing all the sometimes heavy packs of laboratory tests that are requested for PrEP initiation, for example, that are beyond what WHO suggests in terms of lab. So we're suggesting to deprioritize those. And again, these will be decisions made depending on context and national guidelines, of course. In terms of HIV treatment care and support, a full package of treatment, including the procurement side as well as service delivery, continues to be highly prioritized, including the use of optimized regimens for adults and children. And WHO released guidelines on that last year. Highlighting as well the priority to deal and manage with advanced HIV disease that we know also has a big role in terms of mortality and incidence reduction as well. And while prioritizing all of this, potentially deprioritizing specific surveys on drug resistance, for example, obviously wherever the resources are available, we continue to be supportive in terms of including it. In terms of HIV, TB HIV programming, as an example of prioritization, it remains a priority to continue to screen in both ends, TB and HIV, in every contact with the health facility, potentially moving away from more expensive diagnostics, for example, C-reactive protein in terms of screening for TB, just as an example. In terms of cross-cutting considerations, again, you see in the info note, there's a section on product optimization in terms of the health products. And again, there are always, there's new guidelines, for example, for tests, WHO released, there's more options now, they're more cost effective. So we're really encouraging countries to look into these cheaper options and again, moving away from higher cost pharmaceuticals, diagnostics and products whenever there's alternatives that are lower cost, quality assured, etc. So I think I'll end here. Hand over to Jamie for the TB info notes. Thank you.
I think it will be Barcelona for question and answers. Yeah.
Thanks, Bea. Thanks everyone. We have some questions. We're going to move to some of the questions that are related to RSSH. I didn't see anything specific to HIV, but please, we ask you, if you have any questions on the presentations that we've just seen, we ask you to put them in the chat. There's only a few that are related to that. We ask the rest of the participants that if there are any questions that are not related to RSSH and HIV, we'll be responding to them by email. Shun, if there's anything you want to say in terms of the allocation methodology to better integrate climate resilient health systems, we could go to that. Hannah will also comment briefly on the allocation methodology, but then we will move to the next questions, and we can leave some of the others for the end. So Shun, if you want to go to number 1.
Sure, thank you for the question. So as you know, the allocation is by disease. So communication on allocation will be by HIV, TB, malaria, and then you will have a discussion in country to see how much of the RSSH investments will come from different disease components to make our integrated RSSH request. And climate resilient systems or climate resilience is a part of the RSSH investment. If you read the information note and modular framework, climate-related activities are all knitted into each of the thematic area of the RSSH investment. So you actually have flexibility to propose the funding around the climate-resilient health system through the RSSH component of the investment. I hope that answers the question.
Thanks, Shun. We have a question also on integration. We will have key messages presented on integration later in this presentation. So for the CCM of Mozambique, if you can wait until the end of the session to see if you still have this question. For the question number 2, is there room for countries to make a change or add relevant players as sub-recipients after prioritization exercises? Michael, if you want to respond to that.
Thank you. I think that, what's really critical in the funding request 1 is the strategic direction of the investments. How is the CCM proposing that the global fund investments are going to be catalytic? Another part of it is proposing who the principal recipients will be as part of the funding request. And then it's typically the principal recipients that will then select the relevant SRs for the sub-recipients for the grant. What the Global Fund is looking for is to ensure that for the principal recipients and for the sub-recipients, that they have the proper capacity, track record, and the ability to work effectively to deliver what's in the results. And that's really an accountability at country level to choose those correctly. So yes, if we have underperforming principal recipients or sub-recipients, then this is an opportunity to either consolidate under principal recipients or consolidate under sub-recipients. So there is flexibility at country level to add or change SRs.
Okay, thanks, Michael. Hannah, would you like to come briefly on country allocations?
Hello, everybody. I'm Hannah Grant from the Strategy and Policy Hub at the Global Fund. There are a couple of questions on the allocation methodology and about the changes that have been made for this cycle by the Global Funds Board. And the main changes that have been made have been to further prioritise lowest income countries and those with highest absolute burden. So proportionally, we'll see a shift of funding more towards those countries. And it's probably also important to note that although we did have a very successful replenishment in the context in which we are existing, actually the total sources of funds that are going to be run through the allocation methodology are actually lower than in the last cycle. So overall, the amount of funding we have is slightly lower. So it could be that some higher burden, lower income countries do receive a little bit more money, but most of the allocations will be reduced. Thank you.
Thanks, Hannah. We can move to the next slide. Shun, these are questions in, there's some questions in French on RSSH. If you're on the, if you want to go ahead and respond them, if not, I can read them for the rest of the audience for interpretation. Est-ce que la RSSH prendra-t-il en compte l'appui aux réseaux et plateformes communautaires, y compris CLM?
So, will RSSH take into account the support of networks and community platforms, including SLM? If that's the case, to what extent? Another question. In each of the countries, there should be just one single proposition, or for funding demand for all the maladies, all the diseases, and there's also PPR.
Sim, podemos voltar a ler as perguntas
Can we include
para
the
serem
PPR
traduzidas.
indicators in the community monitoring
They're asking if RSSH
devices?
will take into account
Estão perguntam se o sistema de saúde resiliente vão ter apoio a redes e plataformas comunitárias, incluindo o CLM. E para o BPR vai haver indicadores relativamente às comunidades. A preparação e a resposta ante pandemia se vão ser contempladas com sistemas comunitários. Tudo o que é comunitário
how we want the community-led monitoring to be a main part of the quality improvement, and also some encouragement to have community-led monitoring to be more integrated into the government system, and also integrated not just the disease specific, but covering the multiple disease areas. And happy to have somebody from the CRG to supplement it. And then for the PPR, yes, the indicators related to the PPR items like the surveillance, early warning surveillance and response, oxygen, particularly focused on sustainability, are all part of the investment guidance.
Thanks, Shun. Lindsay, if you want to come quickly on number 7, in terms of est-ce que chaque pays doit soumettre une seule proposition de demande de financement TB, VIH,
If each country needs to submit a single proposal of funding demand for VIH, malaria, and TB?
I'm just waiting for the English translation to be done. Okay, so just so that those of you who are listening to the original voice, if you want to listen in English as these questions are being translated into English, you need to go into the English channel. On the bottom of your screen, there's a little world. You can pick the English, French, Spanish, or Portuguese channel to listen to, just for the next time that we're doing this Q&A session. The question that was asked is about whether or not it's required or what are the options to be able to submit a request to the Global Fund? Is it for one grant? Is it for one funding request? So I'll give a brief response, which is The Global Fund requires that all funding requests for the total allocation are submitted at the same time in the same submission window, and ideally, it is integrated into one single funding request that includes all the eligible disease components and RSSH. So the requirement is for all the funding requests to come at the same time, and that needs to be submitted by the official applicant. Often that official applicant is the country coordinating mechanism. So the Global Fund does not receive applications for funding from other organizations. They need to be coordinated by the country coordinating mechanism, the CCM, for each of the eligible countries.
Okay, thanks, Lindsay. We were checking on the translations channels. Normally, when we read in French, you get the translation in the English channel, so people do not need to change channels. But let us address that in the backstage. So, in terms of the low priority activities under removing human rights, I suggest we wait for that question to be addressed when our colleagues from Community Rights and Gender Department come in later to talk about key messages. If we move to the next slide, because we do want to start moving to the next presentations. I think Sean probably would want health be a priority in general for GC8, and then the workforce for CSO like peers. So question 13 and 14, if we can address.
Sure, and also question 11, is it to me on M&D?
Yes, on the side of M&E, if I understood correctly, I was leaving that for Samantha later, but yeah, if I understood correctly, the list of activities listed on this list are not going to be taken into account by the Global Fund.
Yeah, so if I understand the question correctly, if not, apologies. In the information note, there's a table about what's priorities and also what we discourage or lower priority list. If the activities are related to lower priority list, there's a reason behind it from our thinking, but you have a reason probably to propose those activities based on your country context. So then you can really justify the reason why you still want to do those activities. This is not just limited to M&D, but all the thematic areas. So you have, of course, justification, and then you can still propose. There are some items we say out of scope. That is, in our thinking, out of scope of the Global Fund funding, but there are not many of those. And then in terms of the question number 13, One Health, yes, is in general priority. We don't necessarily use One Health language itself, but the integrated surveillance and response mechanism is in general really a priority for GC8, but we don't fund the surveillance related to animal diseases. So we focus on the human diseases, but the other concept or integrated early warning surveillance and response and then pandemic preparedness and response, that's partly really covered in the Grand Cycle 8. And then primary care workforce for CSOs like peers, those are, yes, still very much integrated into our work. So when you look at the human resources for health, the peers are an important part of the health workforce. And ideally, where relevant in the country context, of course, those peers can be integrated into the country's primary healthcare workforce. But when it's not possible for different reasons based on the country context, of course, we still need to support peers, particularly that covers the key and vulnerable population. So there are flexibility around that based on the unique country context. But generally, direction of travel is really to make those workforce integrated into the country system and integrated to cover broader key priorities for the health sector. Thank you.
Thanks, John. We're going to go to the next slide where, as you may have seen, we're grading the questions that we're responding at the moment that are addressed to the presentations that we just had, but we need to move forward. So from this slide, Beatrice, if I can ask you to respond to question 19, you can respond in English and the interpreters will translate into French. Thank you.
Sure. So the questions is in terms, I think, prevention of mother-to-child transmission in terms of testing pregnant women, if there's going to be a new guidelines from WHO with regards to prioritizing. So not to the extent that we know, the WHO guidelines remain to be universal testing of this population. However, if you've seen our reprioritization approach as well as the info note, what we are supporting is some sort of geographic prioritization if necessary. So that means in terms of global fund investment, so we're really not talking about guidelines here of the HIV program itself in countries, but for global fund investments, if we need to focus our investments in regions where HIV prevalence is the highest, we should potentially do that. And then where we provide HIV testing, that we make sure that we provide the whole cascade of care. So testing, treatment, and then infant follow-up and early infant diagnosis. So again, thanks for the question, because it's an important distinction to be made. It's not a changing guidelines, but it really refers to prioritizing potentially global fund investments if it needs be. Thank you.
Thanks. We're going to move back to the presentations. We received a lot more questions that we're moving to the end, but we'll try to respond in the next part of the Q&A. Jamie, if we can go on to the TB presentation, please. Thank you.
Thank you, Marcella. Greetings, everybody. I'm Jamie Tonsing. I'm the disease advisor for TB. I'll be presenting some of the updates to the TB information note for Grand Cycle 8. Next, please. This is the outline for the TB information note. And we have the bold prioritizations really covering the key messages that Michael already covered about. We have a section starting that's with cross-cutting considerations. And then section 2 is really the TB-related sections that you're already familiar with from previous Grand Cycle. It covers topics by the whole cascade of care, starting from screening to treatment to prevention. And what you will note here is that community, human rights, gender equality, they're part and parcel of the TB information note. So unlike in the past where we had separate information note, these are very much central to what we need to do as a part of TB response and are presented here likewise. Section 3, because we are talking a lot about being value for money, integration. So we pull some examples together that are published and as examples that we would like to see more of. And then we have listed the program essentials as an annex. Next, please. These are the main updates to information note, very similar to what others have presented. So I will not really be speaking about them. It's really about how we've categorized priorities into high priority, low priority, low priority, and the program essentials, the emphasis on integration, innovation, value for money, and the updates to what is newly recommended by normative guidance since the last Grand Cycle 8 TB information, Grand Cycle 7 TB information note. Next. So I picked on one section of the information note to show you and give you concrete examples of how the prioritization is done. And on this slide, you will see the example is for the topic of TB screening and diagnosis. It's not exhaustive. So in TB screening and diagnosis, what will Global Fund prioritize to fund? So this will include Number one, implementing screening and diagnostic algorithms that are sensitive, accurate, and efficient. For example, using chest X-ray with CAD AI because it is much more sensitive compared to symptom screening, and also really going on to use rapid molecular tests as initial tests instead of sputum microscopy because it is much more sensitive and specific. Similarly, we expect that there'll be new near point of care TB tests that will be recommended by WHO in this grant cycle 8, and that will be able to help us decentralize testing services to much more peripheral levels that will enable us to reduce the cost of these diagnostic tests. So we are hoping that countries will prioritize these new technologies in their GC8 application. And similarly, I think the others were like intensifying screening and testing for TB in health facilities, also moving to community outreach, targeted active case finding, and integrating TB services into essential healthcare packages and systems. So what's the lower priority? I mentioned sputum microscopy, for example. We will not be funding that for diagnosis. It does have a role for monitoring treatment progress, but probably something that can be met through domestic fund rather than global fund funding, which we expect to be more catalytic than the past. And we see, for example, sometimes instances of people programs that continue to prioritize active case finding among population groups, despite it not yielding the number of cases or not really showing results, but repeatedly continuing to do that. So those are things that we want to be better monitored and to stop doing so if you're not getting the expected results we expect from there. And then for other considerations, how can we be more efficient and effective? Maybe identifying hotspots, people, high-risk populations who live in a concentration geographical locations. That could be, or in some countries we do vulnerability assessment and check about where are the locations where people are concentrated who live together, where there is the vulnerability index is very high, including those to really target for active case finding. And in this also, we are saying that how can you save cost of cartridges? Then maybe there are ways you can do that by sputum pooling or by changing your algorithm to require less molecular costly tests by bringing X-ray upfront. So really looking at ways to be more efficient. Next, please. So I spoke about the example on screening and diagnosis here, and I will not repeat that. That is the first row that you will see there. But you can see that across treatment, for example, we are prioritizing the standard treatment of 6 months for adults, and then the new one for 4 months for children with non-severe TB. But you will see on the right hand, on the lower priority, we are deprioritizing drug-sensitive TB treatment with 4-month regimen for people over 12 years. And the reason for that is because this regimen, though recommended, costs 4 times more than the standard 6-month regimen. And the pill burden is very high, but it does not really offer better treatment outcomes compared to the standard 6-month regimen. So it's low. For DRTBs also, there were new recommendations that came. The ones in bold in this table are the new recommendations that came after the last information note. So they are included in this current GC7 note. So for example, besides the BPAL M regimen for drug-resistant TB, there is another 6-month regimen that is recommended. We are saying let's prioritize use of that for people who are not eligible for getting BPAL-M. But there are other 9-month regimens. They will be lower priority. If none of the 2 6-month regimen does not work, then only you consider from 9 months for lower priority. On prevention, we are deprioritizing antigen-based skin tests. We are prioritizing antigen-based TB skin tests and deprioritizing interferon gamma release assay because they are much more costlier and they're also cumbersome because it requires lab tests, collecting blood samples, etc. For TB preventive treatment, similarly, we're saying let's focus and make sure first that children who are less than 5 years, people living with HIV are prioritized for TB preventive treatment. before we go to the larger groups who are eligible for TPT, such as other adolescent and adult household contacts, other risk groups. So it's really, really prioritizing. If you have enough resources, of course, we want to do for everybody, we want to give TPT for everybody who's eligible. But when you're pushed to prioritize, then that's one way of prioritizing. We expect TB vaccine introduction costs could be needed in the last year of GC8. For example, if you want to do some assessments or your needs estimation, developing guidelines, really the country level, in-country introduction plans. For that, we're encouraging people to include interventions in the last year of the grant. And on strategic information, we are prioritizing the routine TB surveillance systems, really going case-based digital real-time and periodic surveys. At the same time, we are reprioritizing surveys that are very costly and that cost millions, like TB prevalence surveys. They'll only be funded only in exceptional circumstances. Typically, this would be if there were other domestic or other funding sources to co-fund that. Otherwise, it would be very rare or unusual for Global Fund to foot the total cost of TB prevalence surveys as we've done in the past. And like that too, we have other cross-cutting interventions that I have listed there. I'll only say that in this cycle, we have made sure to include people who are affected by extreme weather events and climate impacts, and people in fragile and conflict-affected settings as part of the prioritization we have for key vulnerable populations. These are included as KVPs and prioritized for targeting, for active case finding, for improving access to services. The next slide is my last slide. And it's here really to remind you that we had introduced program essentials in GC7, and this continues in GC8. And as you know, these are derived from normative guidance. They represent a summary which we think are essential for countries to make progress towards to meet the 2030 Sustainable Development Goals and the Global Fund strategy targets itself. So we hope and we expect to see continued priority to all these TB program essentials. To note is that most of them are relevant to every section, but for example, some of them may not be. As an example, when we talk about the program essential on private sector engagement, PE11, this is of course relevant to countries where there's a large private sector and where people who have TB symptoms get treatment and are taken care of by there. But in some countries, there are no large private sector, then maybe it's not important as much as it would be in other settings. So with that, I will pass on to Rupal to take us through the malaria information note.
Great, thank you so much. You can go to the next slide, please. My name is Rupal Patel, and as Jamie said, I'm going to walk us through the malaria slides on behalf of the malaria team. Our table of contents and the format of the info note is very similar to the other diseases, so I won't walk through all the components, but just also to reiterate as, oops, sorry, my video was off. Just to reiterate, as Jamie said, community, human rights, gender equality considerations, and RSSH considerations are integrated throughout each intervention area. You can go to the next slide. The malaria info note reflects the key strategic shifts and adaptations for GC8 that Michael discussed at the beginning of this session, and that were again reflected by my colleagues. And you'll see them here listed on the slide. So I won't go through them all, but what I want to do in the next few slides is to try to highlight the key programmatic and technical considerations and changes which align with these themes that we have included in the information note, and orient you to what you will find when you read through every detail. You can go to the next slide. As in past cycles, our note starts with framing of the overall investment approach before we get into the details in each intervention area. And as an overriding principle for thinking about the funding request and overall investments for the global funds, the the funding request should really prioritize high impact evidence-based interventions drawn from subnationally tailored national strategic plans, of course, based on the local context, with the goal to reduce malaria and morbidity and mortality through high coverage of case management and prevention services. None of this, what I have just said, is new to anyone, but there have been some changes since the last cycle. There have been a lot of advancements in the partnership and work in countries to advance SNT, more tools on prioritization, development of costed operational plans, and all of these things are even more critical given the tough prioritization decisions that we will all face, the malaria programs will face moving into GC8. And I just want to highlight the key issue around balancing case management and prevention. There will undoubtedly be decisions around scaling back interventions that will have to be considered. But the balance of the two is very key. For example, if we do see pullback of some prevention, it might then impact your case management needs. In fact, driving up cases, increasing your needs for RDTs and ACTs. So we know that in each context will be different. The prioritization decisions will require careful thought and trying to get this balance right. And we would request, that you put this sort of thinking into the funding request so that we can understand how you've made investment decisions. And there is a lot of partnership efforts around this area that can help support. And then for cross-cutting areas such as surveillance, M&E, and SBCC, these should not be blanket approaches, should be more targeted to what is essential and where it is needed most. And we've included considerations for all of these areas, as well as operational efficiencies in each intervention area. And then lastly, as always, we really need to have the funding request consider every source of funding. Attention to co-financing, it was already highlighted earlier, and we'll hear a whole presentation on STC. But specific for malaria, we ask that you look at co-financing areas around RSSH components that Shun outlined, such as HRH, community health workers, and some service delivery costs. Potential commodities could also include SP and RDTs, and we've included these in the notes. If you can go to the next slide. What I'd like to do is give a concrete example of how we've reflected these various considerations in the intervention areas. What you see here is the vector control and specifically looking at ITNs. And we framed each intervention with priorities, such as you saw with the other diseases, priorities for consideration for global fund funding, lower priorities, as well as some of the optimization and efficiency approaches. And for NETs, there are multiple components. I'm just going to highlight a few, but there are a lot of details in the information note that I would suggest that you look to. In addition to outlining ITN strategy that you plan to include based on your insecticide resistance data, your epidemiology, and your populations at risk, as well as their barriers to access and care. We also suggest that you consider different deployment strategies and not just relying on costly, labor-intensive mass campaigns. And this is a shift from usual thinking, but there has been a lot of work around continuous distribution channels and other approaches that can maintain coverage without using a mass campaign. Of course, it will be context dependent, but something for consideration. And then in terms of prioritization of where the nets would go, looking at high and moderate burden areas to the most at-risk populations. But we know if coverage cannot be maintained, we'd also want to understand how the risk of resurgence will be mitigated. Another new point for GC8 is that in areas of confirmed insecticide resistance, we will not support pyrethroid-only nets. We will focus instead on the pyrethroid chlorphenipir dual AI nets and PBO nets using the standard specifications that are in our Global Fund procurement guidance and which have started in GC7. For lower priority considerations, just as an example, for NETs, looking at not including major urban areas for distribution and instead relying on other malaria interventions. And then for optimization and efficiency approaches, we've learned a lot from GC7 reprioritization and all the work you and partners have done around efficiencies for campaigns. These should be continued, and there's a lot of guidance from AMP, for example, and other partners around distribution approaches in resource-constrained settings. If you can go to the next slide, please. Here we have a few additional examples across the other intervention areas. Again, I won't go through all of these, but what I would like to do is highlight a few and then encourage a careful read of all the different intervention areas to get a better sense of how we're framing the different interventions. But two things to highlight. You will see under case management and preventive therapies that there's a continued emphasis on integrated platforms, really reinforcing the messaging you heard from Michael, as well as from Shun, leveraging community health workers, ANC EPI platforms, and of course, continuing to do so with primary healthcare as Malaria has already been doing. In case management, we've included concrete guidance on RDT selection. We continue to emphasize addressing biologic threats and ask that you look to prioritize surveillance for drug resistance and gene deletions. And we also have a very detailed section on antimalarial drug resistance. And really this speaks to both addressing biologic threats as well as the point on still continuing to promote innovations. There are newer approaches and newer drugs to address drug resistance, and even in prioritization challenges, the continued reliance on only one drug or one ACT has potentially severe long-term consequences. Therefore, we're really encouraging antimalarial drug resistance strategy development and promotion of supporting elements of the strategy in the funding request, planning for diversification of your antimalarials, and this includes also considering MFT approaches, and doing so in collaboration with the partnership as well as us at the Global Fund, who are making a lot of efforts to try to make alternative ACTs more affordable with next generation market shaping activities. And then my last point, again, just to highlight on strategic information, is around thinking about alternative approaches to data and surveys versus large-scale national surveys. But of course, nothing on this list that's under the lower priority is an absolute, just to reinforce that there are context-specific factors that may mean that in your context and in your country that a certain thing should be included and prioritized. But it just gives you a flavor of how you might need to justify or consider the various aspects of the different interventions. I think that is my last slide, and I will turn it over to Marcella for further questions. Thank you.
Thanks, Rupal. We have lots of questions, as I was saying, that are not related to the presentations, and we're going to try to respond at the end of the session. But obviously, we have a few more presentations, and we're running out of time. Jamie, if you can go to question 73, which is related to TB, and then we'll try to address the next questions.
Yes, so thank you for that question. In fact, that is correct, the question there. On the TB prevention, I did speak only about TB preventive treatment and vaccine, but it very well covers other prevention, including infection control and biosafety part of prevention. But what we've said this far is this infection prevention and control is very much a health system issue rather than a TB specific issue. So we don't want it to be like addressed only from the TB lens, but more as a overall health system perspective, cross-cutting issue, rather than just doing IPC only for TB. That would be the change in approach that we are saying in the spirit of integration. look at it from an integration lens than from a TB specific issue. Thank you.
Thanks, Jamie. If we can go to the next slide. Yeah, we have Jamie 77 not finding the smear microscopy is not realistic because the fund allocates for TB cannot be sufficient to cover molecular diagnostic. Would you mind responding to that one? It's more a comment than a question.
So I think that's true. In fact, in the TB grants, the funding shortage for TB is not just an issue that we're dealing in grant cycle 8. It has always been the case for many, many years. If you look at the financing for TB in the global, in the WHO report, every year, the TB funding available is never above 50%. So given that, you have to prioritize. So for Global Fund, we're saying that Global Fund cannot fund everything that's the need of the National TB Program. TB smear microscopy is important, it has a role, but when we have to prioritize what we fund, we want to be funding those that have the most impact, funding those that are innovative, funding those that allow you to make progress against the disease, as we define in Program Essentials. And in that spirit, we are prioritizing funding Global Fund investment for WHO recommended rapid diagnostic tests like the GeneXpert, the TrueNAS, and hopefully in the near future, the near point of care TB test. So it's just from Global Fund prioritization lens, smear microscopy is much lower in terms of priority than the other tools we have. Thank you.
Thanks, Jamie. And the last one for you on this slide is where does TB LAM fit in the priorities?
The TB LAM is in fact as part of the TB HIV prioritized activities. It is one of the diagnostics we're promoting, and it is especially mentioned now because WHO has come up with a recommendation for concurrent tests for people living with HIV and for children who have TB. So TB LAM is part of the concurrent test for TB and HIV patients and are included as priority interventions for TB and HIV tests in the information note.
Thanks, Jamie. If we can go to the next slide, there are two more questions on TB. For TB 81 and 85, on TPT, why you don't prioritize C6 LFX for the RTV contacts, and could you provide clarification or evidence on not supporting TPT among contacts as low priority?
All right. Yeah. On TPT, on question number 81, it is true we prioritize 6 months levofloxacin for contacts of drug-resistant TB patients. It's just that I did not present that in the 3 or 4 slides that I had. But if you go to the information note that is now published and available on our website, you will find that for TB preventive treatment for drug-resistant TB, this is the recommended regimen based on WHO recommendation. My presentation only covered the TB preventive treatment for drug-sensitive TB, so it was not mentioned here. On question number 85, evidence or clarification for not supporting TPT among contact as low priority. So yeah, in fact, TB preventive treatment, there are a range group of people who are eligible for TPT based on WHO recommendation. So all groups that WHO recommend are eligible for TPT, they should be getting TPT. But when you have to prioritize, I mean, when you have to make trade-offs, we have taken the decision that we are going to look at WHO recommendations and look at the strength of the recommendation. Like, is it high recommendation? Is it conditional recommendation? And also the evidence for the basis for which the evidence the WHO made in recommendation. So if you consider those two things, is it high recommendation or low or conditional recommendation by WHO? If you look at the evidence, whether it's high level of certainty of evidence or low, then there are two groups that WHO recommends are very high in terms of priority for TPT. That is children below 5 years and people living with HIV. And that is why we're saying when you are faced with resource constraints, then at least provide TB preventive treatment for these two groups. If you have money to go beyond these two groups, then go to the other groups. But the priority is really for these two groups, which Global Fund will invest in. Thank you.
Thanks, Jamie. There's 3 more questions for TB, which are great in the slide that you can see, Jamie. And we have one question for malaria. So we're just going to do these 4, and we're going to move to the last part of the presentation because we don't have a lot of time. So if you could quickly respond to this, I'm going to move to Rupal on the last question we have on malaria. Thank you.
86, I will not answer again. I already responded to infection prevention and control, saying that it is a priority intervention, but it should be part of the health system's response, not just a TB specific response for infection prevention and control. On vaccination, yes, Gavi is a player for vaccination. So we still haven't really thought through how this will shape up in terms of, but there is, my other colleagues can also come in on that in terms of collaborating with Gavi for vaccines, as we're already doing for malaria, for example. There are ways we work together with Gavi on the malaria vaccine. We're also working with Gavi on many health system related areas. So we will have to see how we work together as we get ready to roll out TB vaccine in the future. It also has to be linked with how countries are planning to roll out TB vaccines in the country when it becomes available. Is it something that the national TB programs will lead, or is it something that the vaccination program, EPI programs will lead? Those are questions that we have to start asking and answering as we move closer to the availability of that. So no clear answer there, but that is indeed how we roll it out has something we have to look at. Question number 90, will community intervention not be considered within prevention thematic area? Yes, it is. Community intervention is considered within TB prevention thematic areas. For example, we already have examples in countries about community-based organizations, community health workers, really doing the contact investigation for TB and for people who are eligible for TB preventive treatment, making sure they are assessed, to making the community health workers bring them to the health facility to assess whether they should get TPT or not. So that is already happening. And another area is really we face a lot of hesitancy to accept TB preventive treatment from patients as well as their parents, because many often people who have TB infection and are eligible for TB preventive treatment, they are not sick, they are well. They need to get the preventive treatment because somebody in their family had TB and they acquired the infection, but they're not sick. So it's very difficult to convince parents why a child needs to take a medicine for 6 months, even though he's unwell. And I think that's where we've seen good examples of how community health workers play an important role in addressing and creating a demand for TPT and supporting people to complete their treatment. So there is a role, and we're already investing in that. And we want to see more of that. Yeah.
Thanks, Jamie. We're going to go to we have time for one question for malaria. Rupal, if you can respond to 98. And then we're going to move to the rest of the presentation because we're almost at time. Thank you.
Sure, thank you. There are a number of questions actually in the chat on malaria. Maybe just to say one thing that, as others have said, it's very difficult to go through every component. So there are excellent questions in the chat about what can be considered or cannot, and I can see that almost every one of them can be answered from the info note once you go through each intervention area. So I would encourage the questions we can't get to for them to do that. And then in terms of question 98, so the gap table with on our website, we'll have the link to the RBM website where the gap tables are. We'll make it easier to see, because I agree with Jerson that it's a bit hard to find. It's on the main web page down at the bottom where it says gap tables. But we, in coordination with RVM, will make it easier for programs to find. And a lot of programs also receive the gap table at the December meetings, the RVM meetings where program managers met. So we'll make sure that those are more easily accessible. And as you noted, we will not be using a separate Global Fund gap table, but using the RVM gap tables for malaria. Thank you.
Alex, if you can move to the next slide. Rupal, yeah, there were more questions on malaria. It's just because we were running out of time, we might be able to respond to them offline. But if there's anything else you would like to add on these questions, let us know. Bea, I know that there were some pending questions on HIV as well, but I'd like to move on to the rest of the presentations because there were quite a few questions on integration and community rights and gender. So I'd like to go through those slides as well. Yeah, okay. All right, we'll move forward to key messages on these presentations, and we'll try to get a few more questions at the end. Thanks. Estrella, please.
Hi, my name is Estrella Lasri, and I'm working as an integration specialist within the RSSH team. A lot of the messages have already been mentioned by all of the presenters before. As you can see, integration is one of the strategic shifts in GC8. But what we refer to when we talk about integration is the strategic processes of delivering HIV, TB, and malaria services in a coordinated way, mostly within primary healthcare at service delivery component and for the broader health systems elements, and as a means to ensure sustainability, efficiency, and responsiveness to people's needs. The idea is to replace the currently more fragmented approach with a unified model to maximize impact and to promote equity and accountability as well as sustainability. And we're artificially dividing it into service delivery and health systems integration, although we know that there's substantial overlap. The idea is that it will help with the shift in mindset to adapt to the current realities where siloed and vertical programs are no longer sustainable, and there needs to be a more integrated approach to protect the gains made against HIV, TB, and malaria, and also to increase country self-reliance. The integration priorities will be defined by each country. There's not a common approach for integration across the board. The idea is that to meet countries where you're at and to move forward in integration according to the priorities. Next slide, please. And this is some guidance on how to plan on integration. There is, I'll mention later, but there's an integration brief that has been mentioned by Shun at the beginning to talk about what we foresee as the planning for integration, as including integration in the GC8 funding request. So the planning should start happening as soon as possible with all key stakeholders under MOH leadership to develop the integration priorities, if that hasn't been done already, and to see what of those integration priorities will be included in the GC8 funding request. There was a question before around scope, and of course the Global Fund will as some of my colleagues have also said, the Global Fund will not be able to cover everything. We will need to focus mostly on HIV, TB, and malaria, but integration means it needs to be broader than that, and the priorities need to be broader than that and address health systems issues that address needs of the overall population health. Lindsay has already spoken to the development of a single integrated funding request, ideally, or submitting all funding requests in the same window. There was a question before on whether that means one PR. It does not necessarily, although we're within the implementation arrangements as much as possible. We want to push for a common program management unit because it will enhance, and led by the MOH, because it will enhance coordination across the different programs. And then using the existing financing levers like strategic purchasing or social contracting to communities for integrated service delivery and budget harmonization, as well as alignment to public financial management systems. Over to the next slide, please. We have several levers to push for this integration approach. One is the integration technical brief that I've already spoken to, and it includes some operationalization examples of how integration can be addressed through the Global Fund funding request. It's not exhaustive. As I mentioned, every country will adapt these strategies, but it's indicative of what should be done within the GC8 funding request. It also includes risks and mitigation strategies for these risks, as well as things such as strategies that improve people-centeredness and improve health outcomes versus strategies that are more geared to improve efficiency and cost efficiency. All information notes prioritize integration, and then there's integration within the funding request form as well, so that the priorities can be included upfront within the funding request form. There will also be other. We will be including also some within a monitoring framework for integration. There's some indicators within the performance framework guidance of the monitoring framework, but there will also be some other indicators that are included as work plan tracking measures. But we strongly encourage countries to add these into the performance framework to follow up on what's being integrated within the country at different levels. There's other outreach that's going to be pursued through CCM engagement. We're preparing some training materials for the CCM. There's going to be an information session on integration, and then some workshops and specific meetings to discuss integration more directly. And of course, there will be Secretariat advisory support throughout the funding request development and throughout the grant cycle. Over. Thank you.
Someone, if you can come in quickly, we're running out of time, but we want to do the last few slides.
Sure. Thank you, Marcela. Good afternoon, everyone. My name is Suman Jain. I'm Senior Specialist Measurement at the Global Fund, and I'll walk you through some of the key changes related to the modular framework. So similar to the previous grant cycles, for the grant cycle 8, the modular framework has been updated to improve the usability, strategic alignment, and responsiveness to evolving priorities. We haven't redesigned the framework, but we have refined it, and most of these updates are focused on the content and not structure, so that the overall hierarchy between the modules, interventions, and indicators remains unchanged. There are 4 key areas I would like to highlight here. First, simplification and usability. Here we have reduced the number of modules, interventions, and indicators, reflecting feedback from country stakeholders and for better programmatic focus. And this streamlining is designed to make planning, budgeting, and reporting more efficient. We have also removed overlaps and improved consistency across the framework. The intention is to make it easier for applicants to navigate the framework and select the most appropriate modules and interventions for their context. In addition, we have clarified the activity descriptions and improved formatting to support better navigation and section clarity. Secondly, the updates reflect the strategic focus introduced for GC8. The updated content reinforces integrated planning and service delivery across programs. It reflects the latest technical guidance from partners and is calibrated to focus on high-impact areas that match country needs. Thirdly, we have expanded the scope to support health systems resilience. This includes integrated climate and health considerations across HIV, TB, malaria, and RSSH interventions. We have also strengthened the role of broader health systems components in driving sustainable impact. And fourth, we have emphasized equity, gender, and human rights. Relevant modules and interventions have been moved from disease-specific sections into the RSSH section. And this shift recognizes that human rights and gender-related barriers are systemic, and cross-cutting, affecting health equity more broadly. In summary, these updates aim to make the modular framework more intuitive, strategically aligned, and better equipped to support impactful investments. We encourage applicants to review the revised guidance and the content early in the planning process and reach out with any questions as you prepare your GC8 funding requests through the usual channels. Next slide, please. So I'll hand over to my colleague, Michelle, for the updates on human rights and gender.
Thank you very much, and hello, everyone. My name is Michelle Reme. I'm in the Community Rights and Gender Department. So as you heard from others, for this Grand Cycles investment guidance, we've really taken the approach of integrating key content related to community systems, human rights and gender barriers within the disease info notes and the RSSH info note. So the message really is that they remain integral to the disease programs, as well as having some key cross-cutting aspects. So I don't want to repeat that, but you may also have seen that we have one separate brief on reducing human rights and gender-related barriers to HIV, TB, and malaria services. And for that one, it's really meant to support applicants to navigate this change that Suman just spoke to in the modular framework, whereby the human rights and gender modules and interventions have been consolidated and they've been moved from the disease sections to the RSSH section. So to manage this change and really mitigate any risks of possible misunderstanding or missing it, we've taken a two-pronged approach. So the first is really to integrate consistent key messages across the information notes, which is what you're seeing on this slide. And then we've developed the technical brief to provide further guidance on what are some disease-specific priorities and the cross-cutting RSSH priorities in these areas. So here you're seeing the three sets of key messages. The first is that the Global Fund has minimum requirements and obligations in our code of conduct and in our grant agreements to ensure that our investments are person-centered and prevent harm. That includes ensuring non-discriminatory care, respect, informed consent, and you see all the rest here, also safeguarding safety of data, staff, and clients. And of course, implementing our prevention of sexual exploitation, abuse, and harassment measures. The second key message is that programs and applicants should integrate human rights and gender considerations across their programming and services. What this means is really keeping the focus on ensuring equitable access, uptake, and retention for key and vulnerable populations, adapting services to address different barriers that are faced by women and girls, men and boys, and gender diverse people, and also designing services with and for affected communities to ensure that they're not just available, but they're accessible, acceptable, and of good quality. So principles of human rights programming. The third key message is that in addition to taking this lens, there are some very specific programmatic areas of investment that are needed to be able to directly remove these human rights and gender-related barriers. And those are aligned to the program essentials that colleagues have spoken to already. This is a non-exhaustive list, but it includes training health workers to reduce stigma and discrimination, strengthening accountability and legal empowerment, as well as implementing tailored peer support, but also responses to gender-based violence, including integrated care. So the post-rape care, sorry. If you can go to the next slide, just to flag, this is specific to the technical brief itself, which really consolidates all the human rights and gender requirements for applicants, and then focuses on providing guidance and some clarity on how applicants can approach prioritizing within the disease-specific and the cross-cutting interventions to reduce barriers. Key message here is that this shift in the modules and interventions to RSSH is really a change in the budgeting tool, but it doesn't suggest or implicate a change in the programmatic guidance. These remain key integral parts of disease programs to ensure equitable access to services. So what it means now is that any disease program or any grant can select from these two modules and from the 9 interventions within the module, across the modules, based on the specific barriers that need to be addressed. So here are just some examples of the cross-cutting priorities we're seeing for human rights barriers. We're talking about integration of human rights considerations in pre- and in-service training of healthcare workers, strengthening laws, regulations, and policies to enable equitable access, legal literacy and access to justice for people affected by the 3 diseases, to know their rights and to seek redress. But then we have some examples of disease-specific priorities. So capacity building of rights-based law enforcement practices to protect HIV key populations. There was a question specifically about community mobilization and advocacy for by TB survivor networks to reduce stigma. So that remains a disease-specific priority area. Legal empowerment to ensure pregnant women can access malaria treatment and prevention without spousal consent is a malaria-specific one. And then within gender, the gender module, we have cross-cutting priorities that tackle gender norms and discriminatory practices that increase disease risk and restrict access and utilization of services, as well as more generally strengthening and integrating gender-based violence response services within the disease services, the HIV, TB, and malaria services. But then disease specifically, the HIV program essentially included a specific care for intimate partner violence identification and first-line support and post-rape care. For TB, we're looking at engaging men and boys through peer education, community campaigns to improve their care seeking and treatment adherence. And then the last malaria one is, for example, is reducing gender-related barriers to ANC care, which is a key area for malaria prevention. I will stop. I hope that this additional guidance is helpful. Before I stop, there's just one point I wanted to speak to that was asked in the questions, whether there would be a CRG allocation. No. Of course, the allocations are still provided by disease, and investments in community systems as well as in reducing gender and human rights related barriers are to be included in the disease and RSSH allocations. There was a question about matching funds, just to say there will be, some countries will be offered matching funds for investments in human rights and gender related barriers and community systems, and a limited number for social contracting as well. So hope that's helpful for now.
Thanks, Michelle. We're running out of time, but we have one more slide if people can stay on, please. Moving on to Sean Mee or Darius, if you're on the line for climate and health.
Great, thanks so much. I think it's going to be the last one. Thanks to everyone for joining us this long webinar. My name is Sunmi. I'm Senior Advisor on Climate and Environmental Issues at the Climate and Health team within the Health Systems Strengthening Division. I'm very pleased to share a few key messages on how to integrate and consider climate and health issues into GC8. First of all, I'd like to invite you all to refer to the technical brief on climate and health that was launched as part of the GC8 core guidance material for any further details. The technical brief outlines practical approaches and also examples of activities, concrete activities that can be integrated into existing modules for HIV, TB, malaria, and RSSH modules. This brief should be used obviously alongside other core guidance materials, including the modular framework and info notes. The brief outlines, as you can see in the publication, our simplified action framework on climate and health, providing an integrated approach to address multiple health impacts of the changing climate. We're focusing on 3 pillars in this action framework. Firstly, climate risk management and adaptation of HIV, TB, malaria programs. Secondly, building longer-term resilience of community and health systems to different climate shocks and climate stressors. And thirdly, promoting climate mitigation measures to enable environmentally sustainable healthcare delivery for HIV, TB, malaria. As you can see in the table on the right, climate issues are completely embedded, mainstreamed into existing modules and interventions, avoiding creation of a parallel approach. Climate-relevant health risks and adaptation measures are embedded across all these relevant modules of HIV, TB, malaria, and RSSH. For instance, under the RSSH Community System Strengthening module, we're promoting community-based disaster risk reduction and also community-led monitoring of climate impacts on access to healthcare and also access to essential medicines. Under the RSSH monitoring and evaluation system module, we're guiding applicants to consider enhancing integration and use of climate data for health programming and also disease early warning surveillance systems. Under the HIV and TB modules, we're focusing on minimizing disruption of essential healthcare and increasing flexible and adaptable service delivery models to better reach populations that are most exposed to and most affected by climate hazards, including mobile services to reach displaced populations, Under the malaria module, and an important example we would like to highlight here is seasonal malaria chemoprevention and other vector control measures. These need to be adjusted, taking into account changing seasonality of malaria transmission, including, for instance, making temporal but also geographic adjustments of these interventions based on evolving seasonality, transmission intensity, and also risk of reintroduction due to climate change using the best available information. So let me just conclude a few key messages here as you explore and use this technical brief on how to integrate climate issues into GC8. Firstly, focus on protecting continuity of services with sense of urgency. Essential health services for HIV, TB, malaria are facing increased disruptions as climate shocks are altering transmission dynamics, but also straining health systems. So these evolving conditions are exacerbating existing vulnerabilities, displacing communities, and damaging health infrastructure, and overall weakening healthcare access and quality of care. So we're really, encouraging all the partners here to intensify disaster risk reduction, prevention, and also a more effective response measures to minimize disruption to healthcare and ensure continuity of prevention testing treatment services before, during, after extreme weather events, especially focusing on most vulnerable population in climate disaster prone and hard to reach areas. Second key message here is really the need to strengthen the use of data. The best available climate and health data needs to be used to adapt disease programs and health systems, strengthening interventions to really already observed impacts and also future impacts of climate change. The third key message here is also the importance of coordinating and partnering with climate change and disaster risk management authorities and stakeholders, and aligning our HIV, TB, malaria program interventions in areas that are most relevant together with national climate and disaster management plans and coordination mechanisms. Final key message here is really the integration of climate relevant activities into GC8 will need to prioritize health adaptation interventions that are really integrated to deliver multiple benefits across HIV, TB, and malaria, and making programmatic adjustments using best available information that is out there across climate, public health, and also disaster. And finally, as we integrate climate change into GC8, important point is also about measurement. If we cannot measure this, we cannot manage it. So this point is really also relevant to make sure we are supporting our partners to do concrete climate health action and really moving from rhetoric and advocacy to concrete interventions and achieving impact at scale to protect the gains that we have made, and also especially as we go towards the GC8 multiple challenges our program countries will face. Thanks a lot for this opportunity, and please too feel free to reach out to us, to the climate and health team, for any further clarification and technical support that we may be able to provide to facilitate your integration of climate issues into GC8. Thank you.
Thanks, Remy. And obviously we run out of time, but we just want to share with participants the list of published applicant guidance in the links that I have put in the chat. Michael, I can call you to close the session with some key messages. Just obviously we haven't responded to all the questions that have come in, but we'll be preparing a summary and we'll be responding individually to some other participants that have sent their questions in the chat, and we will collect them and share them as well. But Michael, I leave it to you to close the session with some key messages. Thank you.
Thanks, Marcella, and thank you everybody for joining us today. You've heard that Grant Cycle 8 is different and needs to be different given the context that we're working in. Country allocations will be predominantly lower than countries have received previously, and that's going to be painful, but means we need to make hard choices. And we really need to work together and more smartly to sustain the impact that the Global Fund has delivered in supporting countries deliver on their strategies and objectives. Part of that, as you heard today, is making the adaptations that were discussed today in Grant Cycle 8, particularly around the integration and how that can be a theme for accelerating results. your support in really more rigorously and robustly prioritizing the investments and really looking at value for money and questioning areas and activities that where we're not seeing a proper return. We need to ensure and have your support that we continue to target on those most impacted by the diseases. That's key to reducing incidence on mortality. And you've heard too the importance in terms of pathways to greater self-reliance by countries in public health, using the Global Fund investments catalytically, while also looking in terms of how we work with governments and other sources to increase public financing, domestic financing for health. And also the work that we've done continuously in the Global Fund and with your support at country level to continue to innovate in terms of how we deliver services by those who need them. Thank you for participation today, and thank you more for the work that you'll be doing through the country dialogues and working with country stakeholders to deliver quality funding requests to the Global Fund that will be the basis to support countries achieving their objectives. Thank you very much.